Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Atrial fibrillation is the most common cardiac arrhythmia, and it becomes a greater risk as people age. Today, I'll be talking about diagnosis and treatment options with Dr. Jorge Romero. He's a professor of medicine at Upstate and section chief of cardiac electrophysiology. Welcome to the Informed Patient, Dr. Romero.
Thank you, Amber. I'm excited to be here. I'm also happy to answer your questions.
I know that you've pioneered cutting-edge approaches and techniques to eliminate atrial fibrillation, but let's first explain what AFib is and how it's diagnosed.
So as you mentioned, atrial fibrillation is the most common arrhythmia worldwide, affecting close to 50 million people. And we anticipate that in 20 years, that number is going to double. So it's a very common heart rhythm disorder, and atrial fibrillation or AFib or AF, it's a irregular rhythm that patients are going to feel palpitations, that is going to cause fatigue, it can induce heart failure, and more importantly, patients can develop embolic stroke. The triggers for atrial fibrillation originate in the left upper chamber of the heart or left atrium. And what we usually do to control these triggers is either medications or catheter ablation that I'm sure you're going to ask me about.
Well, you said that people can feel this. What does it feel like? What's the sensation like?
So most patients feel palpitations or fluttering of the heart, a racing heart. If they don't feel palpitation, they can be profoundly fatigued or short of breath.
Does this come on gradually or suddenly?
So it depends. Some patients have short episodes for many, many years before seeking attention. And some patients have a big episode for hours or lasting days from the beginning.
Now, I know that the risk increases as a person gets older, but besides age, what else might increase a person's risk for developing AFib?
So age is the main factor for atrial fibrillation. By age 70, 15% of the US population has atrial fibrillation. And by 80, 25% of the US population will have AFib. So other factors besides age is obesity, obstructive sleep apnea, high alcohol intake, high coffee intake, energizing drinks, some thyroid problems like hypothyroidism or hyperthyroidism, and also heart failure. Patients who develop heart failure have 40 or 50% chances to go into atrial fibrillation.
Does this run in families? Like if my grandparents had AFib, is that something that should be on my radar?
There's always a genetic component, and some patients have a tachybrady syndrome, meaning that there's a mutation in the sodium channel that causes the heart to go too slow, and they might require pacemakers. And the same genetic mutation is going to cause atrial fibrillation, and they're going to require either medications to control the rate or catheter ablation to restore sinus rhythm.
Now, you mentioned this briefly, basically why AFib is so dangerous. What could happen if it goes undetected and untreated in someone?
So there are many problems with atrial fibrillation. The main problem, as I mentioned before, is embolic stroke. That's why these patients need to be on long-term anticoagulation based on a score called Chat-Bus score, okay, that I will explain later. So embolic stroke is the main problem. Second, they can develop heart failure. They can develop a dementia, and they can decrease survival if we don't treat atrial fibrillation.
Did you say dementia?
Dementia, yes.
I think of dementia with the brain, but of course, I guess everything's connected. How does the heart or atrial fibrillation contribute to dementia?
The theory is patients, when they develop atrial fibrillation and they're not anticoagulated, they start having small embolic strokes that are going to cause dementia.
I see. Now, how do you diagnose atrial fibrillation? If someone comes to you and they feel fluttering in their heart, and maybe they have some of the risk factors, what do you do to diagnose it?
So it depends on the frequency of the symptoms, okay? So if the patient is coming with palpitation and the patient is having those symptoms in my office, We can do just a simple electrocardiogram. But if they have infrequent symptoms, we can either do a 24 or 48-hour Holter monitor, a 2-week event monitor, or sometimes we can put an implantable loop recorder to monitor the heart for 2 or 3 years.
So if I understand correctly, they could have an AFib that comes and goes, or they could have an AFib that's always there.
Yes, of course. So atrial fibrillation is divided in 4 different groups based on the duration of each episode. So paroxysmal atrial fibrillation is when patients have a short episode of minutes, hours, or days, but they don't last more than 7 days. Persistent atrial fibrillation is when the patient have AFib for more than 7 days and less than 1 year. And long-standing persistent atrial fibrillation is when the AFib has remained for more than a year. And more than 3 years, we call it chronic AFib or permanent AFib because it's going to be very difficult to restore sinus rhythm, the normal rhythm of the heart. However, I have ablated patients that have been in AFib for 10 years with very good results.
And is this just an electrical problem? Because you talked about the various EKG monitoring, or would you ever have a reason to do an echocardiogram of someone who has suspected atrial fibrillation?
This is an electrical problem, so that's why we need to do some kind of EKG or even monitor to diagnose atrial fibrillation. But we do 2 different tests. One, we do a transthoracic echocardiogram, an ultrasound of the heart, just to measure the ejection fraction, the contractility of the left ventricle, and determine whether or not the patient has heart failure. And second, we need to measure the left atrial size, okay? And that's going to be extremely important in the planning of the procedure if we're going to ablate those patients. And the larger the left atrium is, the more difficult the procedure is going to be. It's going to be more challenging and the clinical outcomes are going to be worse. That's why it's so important to try to detect and treat atrial fibrillation as soon as possible to have better clinical outcomes.
You're listening to Upstate's HealthLink on Air with your host, Amber Smith. My guest is Dr. Jorge Romero, and we're talking about atrial fibrillation. So let's talk about the treatment for AFib. What is the goal of the treatment?
There are 3 different strategies to treat AFib, okay? One is to control the rate with metoprolol or calcium channel blocker. There are different medications, but we're not controlling the rhythm. So we have essentially abandoned rate control for AFib because we know that rhythm control is superior. For rhythm control, we have 2 strategies. Medications, they're called antiarrhythmic medications, such as plecanide, amiodarone, sotalol. However, all these medications have several side effects, and the rate of the success restoring sinus rhythm with medications is around 40 to 50%. The second pathway is catheter ablation. So we can use different ablation energies. We'll discuss radiofrequency ablation, cryoablation, and the new technology that is called pulse field ablation. So those are for rate and rhythm control. For stroke prevention, years ago, we used to treat patients with Coumadin. Now we have new oral anticoagulants like Eliquis or rivaroxaban. And of course, in patients that anticoagulation is contraindicated, we have left atrial appendage closure device such as Amulet or Watchman.
So there seem to be a lot of options out there. Do you typically start with the medication and see if that works? Because it seems like there's going to be more than one medication possibly. It seems like that could be kind of complicated.
Yes, so a few years ago, we always used to start with medications. And if that medication failed, then we offer the patient catheter ablation for rhythm control. Now we have 6 randomized controlled trials showing that ablation is superior than medications as a first strategy. So now we don't have to wait until one patient fails 1 or 2 or 3 antiarrhythmics. We can just go directly and do catheter ablation.
So what factors help you decide which ablation? Because you mentioned 3 or 4 different types. How do you decide which one is the best one for the individual patient?
So for the last probably 20 years, we use either cryoablation or radiofrequency energy. those two ablation strategies were using thermal energy. So we were heating or freezing the cardiac tissue. The problem is, even though it was a very efficacious procedure, it was not as safe as it is now because the thermal injury can damage the adjacent structures. So you could damage the esophagus, the phrenic nerve, the lungs, or different structures around the heart. Now, with pulse field ablation, that has been probably one of the major advances in the field of electrophysiology in the last 5 years, we can safely ablate patients with atrial fibrillation with essentially zero risk of damaging the esophagus or the phrenic nerve. So far, we've done probably 500,000 cases around the world with this technology, and we haven't had any atrial esophageal fistula that was probably the most lethal complication with atrial fibrillation ablation. So now it's very safe, faster, and probably a little bit more successful than it was years before.
Is the ablation then meant to last for life?
That's a great question. We have outcomes at 1 year, 3 years, and 5 years, and depending on the kind of AFib that you have, we have different success rate at 1, 3, and 5 years. Just to give you an example, if we ablate patients with paroxysmal atrial fibrillation, the success rate of that procedure is in the range of 80 to 90% at 1 year. But if we ablate someone with persistent and long-standing persistent atrial fibrillation, the success rate is going to go a little bit lower, between 60 and 70%. But of course, better than 0% if we don't do anything for those patients. And this is only with one procedure. So if we add a second procedure, the success rate is going to go higher, to 90 in paroxysmal atrial fibrillation and to 80-85% in persistent atrial fibrillation.
Is it possible that a person who undergoes ablation would still need to take some of the medications?
So most of the time, we try to stop the antiarrhythmic medications if the patient is taking any after the ablation. Most of my patients, they're not on antiarrhythmic medications. The patients who fail ablation, the minority of those patients, they're going to require a second procedure or being on medications such as dronedarone. That is a medication that has a synergistic effect after the ablation, and it has minimal side effects. In terms of anticoagulation, it's a complete different topic, because even if you restore sinus rhythm with catheter ablation or with antiarrhythmic medications, based on CHAD-BAT score, based on the stroke risk of each patient, they need to be on long-term anticoagulation regardless of the success of the procedure. But now, if someone has contraindications to oral anticoagulation or they don't want to be on long-term anticoagulation, then we can offer left atrial appendage closure device such as Amulet or Watchman. And this device is a small, like umbrella or plug that is going to occlude a pouch that we have in the left atrium, in the left upper chamber of the heart, that is called the left atrial appendage. And the procedure usually takes 10, 12 minutes. And now it can be done at the same time of the ablation procedure. So we save growing access. The patient is only intubated one time, so minimizes the risk and is more efficient.
So you're describing this pouch kind of off the edge of the upper left chamber of the heart. Do all of us have that little pouch?
We do. All of us have it. So the analogy is like the appendix that you have in your abdomen. We have the same pouch. It doesn't have any function except causing problems, but we have it in the heart, and it's called appendage instead of appendix.
And so if you can close that off, because what's the risk of having it there in the first place? What problem might it cause?
So the problem of having that appendage is like when the patient goes into atrial fibrillation, the blood doesn't circulate properly from the upper chambers to the lower chambers of the heart. So the blood goes into that structure and stays there. And if it doesn't move for 5-10 minutes, a clot can be formed. And those little clots can go into the brain and cause an embolic stroke. Or it can go to the kidneys or different parts of the body and cause a systemic embolism.
So it's a good preventive. And do most people with AFib have that dealt with at the same time?
Now, this is approved by CMS and by most private insurance. So now we're doing concomitant procedures in which we do catheter ablation and we put left atrial appendage closure devices at the same time.
And CMS, that's for Medicare coverage,
Yes,
right?
correct. And importantly, all these patients after an ablation or after a Watchman procedure, the patients need to be on oral anticoagulants for 3 months after the procedure. And at 3 months, we do either a cardiac CT or a transesophageal echocardiogram and ultrasound of the heart, just to make sure that the device is well seated and there's no leaks about the device. And now we have devices that the success rate of these procedures are close to 95, 98%, and only with 2-3% chances to have small leaks about the device. But most patients will be able to stop oral anticoagulants.
So how long does that device battery last?
The device doesn't have a battery. It just occludes that structure, so the blood doesn't go to the appendage.
Now, I know your title is that you are the section chief of cardiac electrophysiology, but I want to make sure we explain what, like an EKG, electrocardiology, what is that? Can you use kind of layman terms to describe it?
Yes, I'm a cardiologist specialized in rhythm disorders. So I put pacemakers, I implant ICDs, and I treat different kind of arrhythmias such as AFib or ventricular tachycardia.
And then the echocardiography that sometimes comes into play as well, that's an image, a medical image of the heart itself, right?
Yes, it's an ultrasound done by a cardiologist.
Now, we hear more and more about digital health solutions and the use of AI, artificial intelligence, in medicine. Do either of those play a role in AFib?
Yes, a major role now with Apple Watches and all these devices that we're able to detect AFib in an earlier stage, which is going to improve clinical outcomes. And also artificial intelligence is being used now to predict which patients are going to have AFib in the future, which is great. And also to predict which patients are going to have recurrence of atrial fibrillation after a catheter ablation procedure.
Do you see patients that get referred to you by their watch where they had no idea?
Some of my practice are patients that have been self-diagnosed with Apple Watch or other smartphones.
Very interesting. Let's talk about how atrial fibrillation changes a person's life from the very beginning when their watch detects this rhythm change and they see someone like yourself. There's a lot of changes in their life. Is that right?
Yeah, I mean, the main change is quality of life. So they're going to feel the palpitations, this feeling of their heart racing. And the main problem is that most of them, they're going to need to be on blood thinners. So they have to be really careful because if they get into a car accident, into a fight, into something, they're at high risk of bleeding, severe bleeding. So as I mentioned before, AFib is very common, but it's very treatable. So now with catheter ablation and left atrial appendage closure devices, patients can have like a normal life after these two procedures. But if the AFib is left untreated, then as I mentioned before, they have higher chances of having a stroke, higher chances of going into heart failure, higher risk of dementia, and higher mortality.
So with treatment, successful treatment, are they going to end up being limited in their physical activity?
Not at all. The patients can go back to normal activity, normal exercise capacity, and a normal life after these procedures.
Does having an AFib history increase a person's risk for other heart diseases or other medical conditions?
Yeah, I would say the main association between AFib and other heart problems is that many patients with atrial fibrillation that are not treated, they're going to develop tachycardia-induced cardiomyopathy, meaning that the heart is beating so fast that the cardiac muscle is going to become weaker and they're going to develop heart failure.
We already talked about the risk being mostly age, so we can't do anything to turn back the hands of time. Are there other things that we can do to lower our risk of this developing?
Yes, I always recommend my patients 3 things. One is to lose weight if you're overweight or obese. So join the gym and do 3-4 times exercise at least per week. Minimize alcohol consumption. In the US, 40% of the population consumes alcohol heavily. And it's important also to make sure that you don't have obstructive sleep apnea. Why? Because obstructive sleep apnea has been really, really strongly associated with atrial fibrillation. So even patients who get catheter ablation and we don't correct the obstructive sleep apnea, they're going to have more AFib. So if you snore at night or your partner tells you that you snore at night, it's ideal that you get a sleep study to diagnose or at least to rule out obstructive sleep apnea.
Are some of those digital devices picking up on sleep apnea for people?
Yeah, so now we have a small kits. Before it was very complicated to send a patient for a sleep study, but now we send the patient with that kit home and they do it at home and they send us the result and it makes the diagnosis so much easier.
Well, that's very good to know. Thank you so much for making time for this interview, Dr. Romero.
Thank you.
My guest has been Upstate cardiologist Jorge Romero, who is a professor of medicine at Upstate and section chief of cardiac electrophysiology. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Spotify, Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.